I'm going to walk from the side. Hello. So, right. Hi, everyone. I thought I'll make an entrance. Hi, everybody. Welcome to the oral presentation session on sex and drugs, part 2. So I'm Eric, your chair for this session, and the moderator for this session will be Becky. And we've got Vikram, who is the backstage manager, who's helping us with the technology if it fails us. I have no idea where to look. My camera's over there. Right, so our role as the host is to make sure everybody feels relaxed, including the presenters and the attendees, so that we can all learn in a relaxed and respectful way. So before we move on to the presentations, I would just very briefly like to remind everybody of the terms and conditions that we have all agreed to for this conference. So we are all here in the spirit of active listening, discussion, and respectful debate in order to address the challenges that we currently face in sexual health, well-being, and social justice in Scotland. We have a zero tolerance policy for any abuse or attack, and if any comments or questions are deemed inappropriate by myself or the moderators, you will not be able to speak or engage any further in this session. Just to give you a bit of a housekeeping kind of introduction as well, each of the presentations will be about 15 minutes long. We've decided to put the questions to the end so that people have time to think over the 2 presentations and ask the questions. You can ask the questions to specific speakers, or you can just say, here's a general question for both speakers. The session is scheduled for 40 minutes, but we have the full hour, so we will make use of the full hour if people have questions for the presenters, and if people want to have some level of engagement as well. If you've got any questions, please put them into the Q&A tab at the top right-hand corner if your screen is the same as mine. So I will pick up the questions from there, and Becky will moderate them. If you want to engage with anybody in the session, you can put it in the chat. I'm not really going to be picking up questions from there because it can get quite hectic in there. So any questions, Q&A. If you want any further information about the presenters or the presentation, you can find it in their bios and the conference brochure. So our session today is sex and drugs. So we're very fortunate to have 2 speakers who will be sharing with us their experience of 2 pieces of research that will speak to the issue of sex and drugs in 2 populations. I think this will make for a very good opening point for discussion later on. So if you've got any questions, please just put it up. So I will hand you over to Irina, who will tell us a little bit about drug use amongst people living with HIV in Scotland. Over to you.
Thanks. I'm just going to share my slides. Is that all right? Can everybody see that? Fab. So thanks to the conference organizers for inviting me to speak today. I'm a research assistant. Sorry if there's ambulances going by. So I'm a research assistant that has been working alongside Alistair for the Stigma Survey UK research for a number of years. We started back in 2015 and have since completed 3 rounds of the survey. And so the Stigma Survey UK is a community-led survey that looks to explore the experiences of stigma and discrimination of people living with HIV across the UK. And the way that we've carried out the survey is we created an anonymous online survey where people can go and share their experiences. And today I'll be speaking to you specifically about drug use among people living with HIV in Scotland. So before I focus on Scotland, I just wanted to give you kind of an overview of the whole sample that we collected in 2019. So we recruited 2,423 people living with HIV across the UK. And we did this through either HIV clinics within the NHS, through community organizations, or through kind of social media. And we recruited 3/4 of the study population that were male, just under 1/4 were female, and about 4% reported being kind of self-identifying as either queer, non-binary, or in another way. We've got about 5% that were under the age of 25. So we recruited people living with HIV above the age of 15 in the UK. And our kind of study population was largely representative of the older age groups. So we see here that half were between the ages of 25 and 50, but then 43% were over the age of 50. And largely identifying as either white British, Irish, or other white. And we've got just under a quarter that identified as Black or Black British. The table to the bottom left just gives you a sense of where people were living at the time of the survey. So we see that about a third came from London. And then we also have some good representation from the Southeast and kind of West Midlands, with the North slightly less represented. And then some respondents from Scotland, Northern Ireland, and Wales as well. And the table kind of to the bottom right here, looking at where people were recruited, just wanted to give you a sense of the comparison between the 2015 survey and the 2019 survey. The first kind of time around, there were more people, about a fifth came through community support organizations that are either working with people living with HIV to provide peer-to-peer support or any kind of other services. Whereas in 2019, really the vast majority came through NHS HIV clinics. And so that's kind of an overview of the respondents from across the UK, and just to focus a little bit on the Scottish respondents. So we had 70 people complete the survey in Scotland in 2019. Again, we see that large proportion, 86% were male, 13 female, and then 1% that identified in another way. Ethnicity as well, comparable to the larger cohort. So we had a large proportion that were kind of identifying as white, and even less in Scotland that were identifying as Black or Black British or other ethnic groups. And then the age groups are kind of largely similar to the bigger cohort, with the older ages better represented. So just to give you a sense of what kind of the survey was about. So the first section was kind of demographic information. Then we asked people about their experiences of acquiring and treating their HIV. And then we kind of focused on kind of three main sections around the experiences of HIV and stigma. So we asked about positive and negative feelings about their HIV status. We asked about their worries or kind of anticipated stigma, whether they avoided any situations as a result of that, and then the main kind of section around whether they actually reported experiences of stigma and discrimination across a range of settings, whether that was in their kind of personal lives, in employment, in education, or within the healthcare setting. And so kind of I presented the kind of the demographic information in the last slides, and now just to take you through some kind of information around people's HIV status. So in Scotland, all 70 people reported being currently, at the time of the survey, on antiretroviral treatment. We asked them, one thing that the 2019 survey had, which the previous surveys didn't ask about, was around undetectable viral load. And so we asked them whether they were undetectable at the time of the survey, and the response options were yes, they were currently undetectable. So that was the first option. The second option was they had previously been undetectable at some point since being diagnosed, but weren't currently, or the third option that they had never been basically undetectable. And so we see from the pie chart on the right-hand side there in the purple that really the vast majority, 99% of these Scottish participants who responded, were currently on treatment and undetectable. And then on the left here, we have kind of information around how long people had been living with HIV. So the kind of vast majority, 4 out of 5, had been living with HIV for over 6 years. Quite a lot of them, actually, out of those 4 out of 5, had been living with HIV for more than 10 years. and only about 4% reported living with HIV kind of for a year or less, so the newly diagnosed population. And so just to give you a little bit more information around the kind of new information that we had around undetectability. So we wanted to understand where people were getting this information and kind of their level of understanding of what it actually means and how this may have impacted on different parts of their lives. So on the bottom left, we see that really the takeaway is that the vast majority are getting this information from within the healthcare setting. So 3/4 learned about undetectability from their doctor, 13% from a nurse, and then really quite a small proportion through either a support group worker or other sources, which, online, for example, or other community organizations. And then what we did was ask them a question around what does undetectability mean, with 4 response options. So only 3 are reflected here because nobody ticked the 4th one. But basically, we wanted to know whether they understood that it either that they could not transmit HIV, if they were undetectable, less likely, just as likely, or more likely. And so we see that in Scotland, 84% identified that they in fact cannot transmit HIV if they are undetectable, and 14%, kind of a smaller proportion, were maybe a bit less sure and identified the less likely to transmit option. And then when we asked them about whether this had impacted their lives in any way, 77% believed that their understanding of undetectability and knowing what this means had positively impacted their lives, whether this be their personal relationships, their sexual relationships, or in other settings. And so now we finally focus on kind of the experiences of drug use within Scotland for people living with HIV. So the first question that we asked was around the different types of drug use. So we see that 70% reported their drug use for a medical reason, just under a third reported recreational drug use, and then just under a fifth reported drug use for performance increase or pleasure during sex. And so what I'll do is I'll take you kind of through now these three groups in a bit more detail. Just to show you here that we did a little comparison of Scotland versus England. And so this graph shows that basically across all three groups, there were kind of less reports of drug use in England versus Scotland. However, I will say that the caveat here is that the denominator of the people who responded to these questions was smaller in Scotland, so obviously the proportions may appear bigger. So this is maybe something to consider and thinking about how these comparisons are made, and whether it's meaningful to really say that 10% difference across Scotland and England, potentially something to think about. So focusing on the first group, drug use for medical reasons, one of the questions that we asked was around whether people had ever been diagnosed with a number of health conditions. And the list was quite long, so these are kind of just the most common answers. But we see that over 60% reported being diagnosed with depression and anxiety, kind of around the fifth mark, 20% had been diagnosed with hepatitis B and C and had neuropathy. And then there were some reports of hypertension and cancer, along with some other health issues there. So now moving on to that second group of recreational drug use. So the first question was generally around recreational drug use. And then of those participants, we asked them whether they injected drugs. And so of that recreational drug group, about a third reported injecting drug use. And then of the injecting drug users, about a third reported being worried about HIV-related stigma. So like I said in the beginning, the kind of questions around experiences of stigma were again, kind of in these three main groups of anticipated stigma, so whether they were worried about certain situations, whether they then avoided those situations as a result of the worry, and finally, whether they actually experienced negative, basically stigma or discrimination. So a third were worried about kind of situations of being gossiped about, being treated differently by family and friends due to their HIV status. But actually, when it came to asking the question around whether they had actually experienced those things, none of them reported having done so. And then so part of the questions were around experiences in the social settings. But one of the things that we also wanted to understand was around stigma and discrimination within healthcare. And so we asked the participants about their healthcare use, so access, whether they go to the doctor when needed, whether they were the ones to have shared their HIV status with their medical teams, and whether they then felt supported within that setting. So here, of the injecting drug users, all had reported that their GP was aware of their HIV status, and they actually felt supported in that setting and didn't feel like they had to avoid going to the doctor because of either their HIV status or potentially their drug use. And so again, one thing to really highlight is that because of the number of people who responded to the survey in Scotland was relatively low, and the fact that we're then now looking at these kind of subgroups of people living with HIV, these numbers need to be taken with a little bit grain of salt, because a third, might seem like a high proportion of people who are worried about stigma. But actually, if maybe the denominator of people who responded to these questions had been bigger, maybe that would have been a little bit different. And then finally, in the third group, taking you through a little bit, people who reported drug use for either performance increase or pleasure during sex. So we saw that 1 in 5 reported doing so. And then we asked a kind of sub-question of the people who had said yes, whether they had self-identified as taking part in chemsex, and we used this term specifically within the survey question. And again, kind of people that reported having chemsex, all reported that their sexual partners over the last year had been on PrEP. So this was another thing that we added in the 2019 survey compared to 2015. There were some questions around understanding of PrEP and kind of PrEP use within their sexual encounters over the last year. And with we asked the question specifically around whether it was with their main partner or with other partners, if that was the case. So and then of kind of in terms of the experiences of stigma and discrimination, of the people having chemsex, 40% worried about being rejected during a sexual encounter because of their HIV status. But then again, when we asked the question about whether they had actually experienced this, they all had said no. And so I guess kind of the takeaway from the presentation today is that in Scotland, the people who are using drugs and who are using drugs during sex seem to be doing so safely. So everyone is on treatment and 99% are undetectable. PrEP is being used where appropriate. And so I think, just the other caveat really is the fact that there are really quite small numbers that we're talking about here. So it needs to be put into perspective a little bit. But I think potentially we can discuss today. I'm sure it'll come up in the questions around how to kind of increase the amount of research and information available to kind of make more meaningful conclusions in this area. And the other thing I want to just say, so that's the end of the presentation for me today, but I just wanted to highlight that there really is a lot of information available to us from the Stigma Survey UK, and we're working currently on putting together some report cards that focus both on kind of the whole 2,423 cohort of people from across the UK, but also specific report cards either on kind of specific regions or specific subgroups of respondents. So there will be a report card coming out specifically on injecting drug users in the whole cohort, and that's based on 76 people, so slightly bigger numbers. And there's a bit more information there around the experiences of positive and negative feelings around HIV status of injecting drug users, and kind of a little bit more information around these experiences of stigma and discrimination. And I just wanted to say thank you, and specifically to the participants who shared their experiences with us and gave their time to complete the survey, as well as our partners, and of course, everyone who helped us recruit. Thank you.
Thank you very much, Irina, for that. So remember, if you've got any questions, just stick them into the Q&A tab. So next up, I'm going to pass the screen over to Rupert, who's going to share with us findings and thoughts around the narrative review that was done, exploring the cultural competency as a model of reducing barriers to care for LGBTQ plus people who use drugs and alcohol in Scotland. Over to you, Rupert.
Thanks, Eric, and thanks, Irina. That was great. That was really interesting. Good morning, everybody. I can't see you all, but thank you all for being here. Let me just pull my little slides up. There we go. Okay, so yeah, my name is Rupert. I'm a newly qualified social worker with Justice Services in North Lanarkshire Council. And today's presentation is based off of my master's dissertation, which was looking at cultural competence as a way that we can reduce barriers to care for queer people who are using substances. And it was kind of born out of my past working experience in substance use services and seeing that LGBTQ people are underrepresented in client groups in these services, but also lived experience as a transgender man in queer communities, seeing that there are high levels of substance use and related risk-taking behaviors in that community. So there was a disconnect for me. I'm so sorry, my cat has just started yelling. A disconnect for me between what I was seeing in people's lived experience and what I was seeing in service use makeup. So the dissertation was very long, so I've tried to distill some of the kind of key findings into this presentation. So just a quick summary of the study. I've talked about where it was framed by. So LGBTQ substance use, we've seen in research and also just kind of anecdotal knowledge that LGBTQ people tend to use substances in slightly different contexts than mainstream drug and alcohol users. And queer socialization, which is something that predominantly takes place in nightlife settings like gay bars and gay clubs. These are landscapes where substance use is kind of promoted and encouraged. And so that plays a big part in the high rates of substance use in this community. I was looking at the data that I was finding from the literature review through the lens of minority stress, which I'll talk about in a little bit. And just seeing what are the barriers to care, like why are LGBTQ people not accessing substance use services, and kind of the common thread amongst the most widely reported reasons that I found was a lack of cultural competence on the part of service designers, so the actual services themselves, and then individual professionals. So there was a gap between what I was seeing recommended in the research and what was actually being enacted in the services. And then finally, I'll talk about some recommendations for culturally competent services. So cultural competency, for those who aren't familiar with the term, it's not really the expectation that professionals will be familiar with every aspect of all of their various clients' personal or identity-based cultures, but is a way of opening up conversations about how people from particularly marginalized identity backgrounds, so people from Black and minority ethnic communities, queer people, working class people, how those lived experiences of oppressed identities inform and are informed by their substance use. So it's been used in the design and provision of substance use support for quite a while now. And it recognizes the connection of people's lived experiences, their trauma histories, and people's social and cultural and economic backgrounds to their substance use. So for LGBTQ people, various things that this might include is if you having LGBTQ clients, a way that you can kind of manifest cultural competency is not to assume people's gender identity or their pronouns or their sexual orientation based on physical appearance. You don't need to become an expert at gaydar, but just opening up a conversation, allowing people to tell you who they are instead of assuming that. Understanding a little bit about the relationship between minority stress and substance use. If you're working in substance use services, knowledge of some of the more commonly used substances in LGBTQ populations and knowledge of the common contexts in which LGBTQ people use drugs. So like I was saying earlier, nightlife settings, and like Irina mentioned, chemsex is a really big one for this community. Oh, my slides are the same color, so sometimes I don't think that it's changed when it has. So minority stress is a psychological theory basically for people who belong to any sort of marginalized identity group, the ones that fall under the Equality Act, for instance, connecting the experience of belonging to these populations to widely documented social, economic, and health disparities. So it was commonly cited in a lot of the research that I was reading as a reason for initiating drug use. So LGBTQ people who, not just because they are LGBTQ, but because they live in a world where being LGBTQ is associated with, interpersonal prejudice, unequal treatment in healthcare, just difficulty accessing services, difficulty accessing education, employment, all of those things culminate in what we call minority stress, and were cited as reasons for initiating drug use, living under that great deal of daily stress. And it's been documented as being correlated with the development of substance use disorders quite frequently. So contributing factors, I ran through a couple of these, but for LGBTQ people specifically, family rejection, unequal treatment in healthcare, social care, and workplace settings, biased hiring practices, creating disproportionate levels of poverty, experiences of direct interpersonal prejudice, discrimination, or violence, and frequent negative views expressed publicly or in the media. We've seen a lot of that in the UK in the last few years, the negative perception of particularly transgender people in the UK media, and just living in a country where you are seeing things said like that about you on a national platform daily can create quite a lot of distress and almost trauma for people. Slide. So LGBTQ drug use, the way that it is specifically different from maybe mainstream client groups of substance use services. Again, chemsex, for those who aren't familiar with that term, chemsex is kind of lengthy sessions of group sex and substance use that is specifically intended to improve people's sexual performance or their duration. So quite often it's GHB, ketamine, or other stimulants and dissociative substances. And there's a lot of associated harms with chemsex, a lot of issues of sexual consent and sexual safety arise because people are using quite a lot of substances and can slip in and out of consciousness. Also for these substances, the kind of protocol for recognizing and handling overdoses isn't as commonly known as maybe that of opioids, because we've seen the ads in public transport at the moment for naloxone for substance use, but naloxone unfortunately only works if a person has consumed opioids. So another one is the use of amyl nitrates or poppers is very common in chemsex, but also just in queer nightlife spaces. So in nightclubs and bars and stuff like that. And these, if you are a long-term and very frequent user of poppers, can have some health risks associated with them. I talked about the socialization focused on nightlife venues. So there's boofing, which is ingesting drugs through the rectum. So opioid use isn't as common in LGBTQ communities. It doesn't not happen ever, but it just isn't as common. Whereas opioid users would make up the vast majority of kind of mainstream substance use service client groups. Injecting of substances, which happens during chemsex, is often referred to as slamming. It's been suggested that this is an attempt to kind of distance themselves from other injection drug users, people who are injecting opioids. So there's kind of a stigma within a stigma happening there. And one finding I discovered was that queer people are often underrepresented in service design and policy, particularly in the United Kingdom, because their drug use is not as largely associated with other criminal behaviors. And UK drug policy at the moment is very much aimed at reducing crime associated with substance use. So if your substance use isn't leading you to commit, theft, assault, any of those kind of things, then you're not really being considered in, the Misuse of Drugs Act, like nationwide drug policy. Those policies, which unfortunately disproportionately target Black and minority ethnic, working class, and refugee populations. And then, sorry, got a little bit lost there for a second. So because we don't know that much, services aren't really set up around LGBTQ drug use, and we don't gather that kind of data in our services. So it's not mandated to gather information on people's sexual identity or gender identity when you're doing intakes or assessments or anything like that. Some people will, but it's not kind of standardized across Scotland. Is that when it comes to resource allocation and service design, because we don't have that demographic information available, this population is kind of falling through the cracks when it comes to planning out services, because we don't have records saying that the population needs to be considered. So that's something to think about. So the barriers to care, the most common one that I came across was LGBTQ people having a perception that mainstream drug and alcohol services were not equipped to support them. And it was dramatically impacting their populations, their help-seeking behaviors. So they were much more likely to go to friends or go to the internet for support than to access services in their community, even if they were widely available. And so that perception comes from all of these things that I've talked about up to this point, of just either they had a negative experience in the past, or they've heard about somebody who went to a service and had a negative experience, and they've kind of internalized the perception that these services, they don't know anything about LGBTQ people. They don't know anything about their substance use. Whether this is true or not, this is the perception. And so there isn't much point in them accessing these services because they won't be able to help them. I talked a little bit, I got ahead of myself. I talked about the information gathering. So this knock-on effect for service design and resource distribution. Insufficient training for staff on the particular needs of this community. A lot of health and social care people in surveys that I read responded that they wanted to know more about how to best serve this community in their service, but they just didn't have that information available to them. And then one that is specific for trans and non-binary service users is commonly in drug and alcohol services, you'll know yourself, they are segregated on the basis of biological sex. So often inpatient treatments, detoxes, rehabs, and counseling groups, there'll be women's groups and there'll be men's groups. And this can become very complicated for transgender service users, because placing a trans person who's using drugs in an inpatient that is set up for their biological sex can bring on really intense feelings of gender dysphoria, does actually constitute discrimination, and can be a huge barrier to them being able to positively engage with the service and positively continue on their recovery journey. But on the other side of that, sometimes placing a transgender person in the service that correlates with their chosen gender identity can be met with quite a lot of resistance from colleagues, like people who work in the service, and from other clients in the service, which can bring on a risk of harm. Trans people are at risk of being either discriminated against, verbally abused, physically attacked, when they are kind of placed in a setting. When you put a trans woman in a setting with a bunch of cis women, there can be quite a lot of resistance and discrimination that happens there. So these are just some of the statistics that I found that I thought were the most interesting. So I'll just run through these quite quickly. 11% of social workers in the UK reported, oh, hang on, sorry. My face is in front of my text, reported not feeling confident in their ability to support LGB clients. And then this went up to 31% not feeling confident in their ability to support transgender clients. 12% of health and social care staff in Scotland reported that their workplace has materials that are inclusive of LGB people, but this went down to 4% for trans inclusivity. So by materials there, I mean like posters, pamphlets, anything that's kind of on display in the common areas of a service. 25% of LGBTQ respondents reported experiencing discriminatory practices when accessing public services in Scotland. This was from a large survey done by the Equality Network in 2015. So that's 1 in 4 respondents. That's quite a staggering number. 43% of LGB respondents would not disclose their sexual identity to social services, and 71% of trans people would not disclose their gender identity. This is from the Fife LGBT Community Needs Assessment. 53% of LGBTQ people in England would not feel comfortable accessing mainstream drug and alcohol services. There hasn't been a similar study done in Scotland to reflect that number. And then 16% of frontline staff would not challenge colleagues or clients making discriminatory comments about LGBTQ people. So one of the recommendations, I know it's at the bottom of the list, but I'll actually start with that, is advocacy, because of that last statistic. Because as well as the 16% who said that they wouldn't challenge these comments, there was a further 60% from the same study who overheard negative remarks either by coworkers or other service users about LGBTQ clients who did not report these to management. So one of the biggest things that we can do to try to foster a cultural competence of LGBTQ people in services is to make sure that they're safe there by advocating for them when we overhear negative comments, negative or disparaging conversations, misgendering, things like that. So the other recommendations that I have: improve training opportunities for staff, specifically around what LGBTQ substance use looks like, or what is required to work positively with LGBTQ people, the things that you should be aware of. Outreach with LGBTQ services and communities that can be combined with training. You know, you don't have to come up with these training materials yourself. They are available from other organizations. Queer inclusive materials on display in offices and services. That sends the message the moment the person walks into the service that they are welcome there, that they have been considered in the design and the planning of this service. Including questions about sexual and gender identity, preferred pronouns, etc. during assessment and intakes. One of the studies that I read, I think 55% of social workers, this was in 2015, responded that they did not believe that a person's sexual orientation was relevant to their health or social care needs. I think that's kind of ridiculous, but we don't have time, so I won't get into it. Making use of available research to inform targeted intervention strategies, acknowledging the interplay of sexual and gender identity and substance use. So all the things that we talked about, how they are connected, like an LGBTQ person's substance use more often than not will be informed in some way, shape, or form by their sexual or gender identity. And so trying to support them in their substance use while excluding anything, to not acknowledging that inextricable link, is going to not be as effective perhaps as if we, have frank conversations about how these things are connected. And I think that's me. So I will stop sharing my screen. Thank you all very much. I apologize if I was speaking really fast. I tend to do that when I'm nervous. So if there's any questions, we will get to that part now.
Thank you very much for that. And thank you. Despite being very nervous, you did really, really well. You can see from all the love and all the claps coming in for you. Great. Thank you very much. Right, we have a question for Irina that I'm gonna put on stage. So while we go through this, if you've got any questions, please put it into the Q&A. It's a question for you.
Yeah, thanks for that. So I think this is of course like the one kind of question that all researchers want the answer to is how do you make your research more representative, more meaningful, to make sure that you capture everyone's experiences. I think it just really is about making whatever you're doing accessible, making it inclusive, making sure that people who you're trying to reach are involved in the process of designing both the survey and your recruitment strategy. I don't have a particular expertise kind of specifically around substance use, so I can't necessarily speak to that in particular, but I think generally speaking, building connections within the communities, building trust, making sure that that the people that you're trying to reach feel valued and that their experiences aren't just for you to publish a paper or speak at a conference, kind of making them understand that, you know, how their answers and how their participation will potentially improve either policy or services that ultimately are for them. I don't know if anyone else wants to add, but yeah, I think it's just really about thinking about your recruitment strategy before you go into it. And I mean, for us, for the Stigma survey, I think it's also tricky because it depends on the resources that both the researcher has and the resources of the partners that are involved in recruitment. I mean, for us, you know, we really made an effort to contact dozens and dozens of NHS clinics and community organizations from across the UK to try to be as inclusive as possible. And some obviously got in touch more quickly and optimistically than others. Sometimes it's just a matter of having the resources to really do the work that you want to do properly. But I think it's just a matter of kind of being inclusive and not coming at it from like a top down, but really thinking about your recruitment strategy strategically and meaningfully.
Great, thank you very much. I've got a question here for Rupert from Rachel.
I am muted. I don't know is my honest question, because to me it seems like such an obvious thing to do. I think, yeah, I'm not really sure. I know that some people, I've worked with people before who, even though it's not included on their forms, they ask it and they write it down. And when you talk to people, it seems it makes sense to them that it would be a part of the information that you gather. I think sometimes intake forms are maybe out of date, and they're from before we started to really consider how these things were connected. I would like to see them added on more, because even if it doesn't end up being useful for whatever the work is that you're trying to do, it does send a message that we aren't just assuming that all of our clients are straight or heterosexual or cisgender people. And so even if they are, asking the question is just one of those things that kind of destigmatizes a little bit more all those little things that we can do that set us on a further journey towards people's liberation and acceptance, I think is really important. It's something that I would really like to see become standardized.
And I would agree that in the idea there that actually all these little gestures actually just normalizes that we are asking this not because it's an extraordinary question to ask, it's because this is a question that we are asking because we care. And I think quite often in the forms as well, I get a sense, I work in services, in sexual health services over the last 15 years in education. I think about forms. I love forms. I have forms and papers everywhere. Sometimes it can make people quite frightened that it is an issue because it's being asked, and therefore people don't want to say too much in case it does impact on their care. I do think there are some people who, maybe the word is not self-stigmatizing, but people who feel worried and concerned that certain characteristics that they do have can impact on their health and their accessibility to care. So to see a question being asked can, I think, for some, probably a minority, can create some sort of anxiety. But I do feel that I agree with Rupert that actually having that question there and the option of do not wish to answer, for example, because that's the reality of forms, you can just don't answer them, actually give people the opportunity to be seen, to be recognized without them having to disclose anything. And that's something that I think a lot of practitioners can find quite difficult to understand, or people who create forms or people who collect data, to actually realize how little things like that actually can mean so much in reality. Because a lot of people take the big step coming into the service already, and they see absolutely no representation within the service. You see either white walls or walls that are very, for example, heteronormative, especially if the posters are quite old as well. In the young people services that we have in Lothian, for example, we have a checklist where we go through and say we would like to have representation of people, like, for example, visible disability, something that talks about race, something to talk about women, just to have those visuals so that people can feel comfortable. And those are a checklist that we have for our young people services. And I'm not quite sure if those kind of checklists are available in other types of services as well, for example, substance use services or harm reduction services. And so I absolutely agree with what Rupert said in terms of it's the little things that actually can mean a lot in terms of representation. Now let's have a look to see if there's any other questions here. We've got a comment here from Alistair. For HIV research to be representative, it needs to be delivered across a range of settings, including NHS clinics. Yes, absolutely. Any response to that? I mean, I don't think there's much of a response to that. Yes. So if you could change one thing tomorrow, what would it be in terms of improving kind of the service for the populations that you are that's of interest to you? If you could say it to commissioners, to office managers, to service managers or practitioners, what would be just that one thing they can actually do tomorrow, would you say?
I can start. So I'm speaking. I'll speak based on actually the responses from people living with HIV who completed the survey, and I think some of the questions that we had around healthcare use. So again, my expertise isn't necessarily around service provision, so I may not speak to that specifically, but I think the questions that we asked around stigma and discrimination within the healthcare setting, kind of a lot of both the survey response options, and we had some qualitative kind of free text boxes for people to discuss their experiences and what they felt about what's going on within that setting, is I think really just education, what we were saying earlier, really about, educating healthcare staff, normalizing certain conversations, raising awareness around HIV and around this kind of undetectability within the public, but also within healthcare staff across settings that aren't HIV specific clinics. So we had some information around experiences of stigma within inpatient and outpatient care, for example, and people reporting experiences from the dentist, for example. So I think it's really just about kind of bringing everyone up to the same level of knowledge and acceptance to run kind of an inclusive and useful service.
I think I would having one portion of a service, whatever form that takes, that is dedicated to supporting this population. So whether that's a group, whether that's a member of staff who part of their role is to kind of address the needs of that population. I think the Dean Clinic is an example that I always kind of pull up, which is a clinic in London, which I think is the only one in the UK that supports LGBTQ people for both their substance use and sexual health concerns or support needs. And so combining those two things and being supported by practitioners who either themselves are queer or have spent quite a bit of time kind of familiarizing themselves on the unique needs of this population has proven to be extremely effective. So I think having services, because there's always the debate of whether people should have only specialized services or whether there should be, better support available in mainstream services. And I think having one portion of a mainstream service dedicated to that population is a way of kind of combining the two.
Great. So I'm going to show on stage something that Alistair has put up. And while we read that, maybe I'm being very mean here, Rupert, but as a kind of newly qualified social worker, my understanding of social work is incredibly busy and is incredibly complex situations that that people have to deal with in your work. And there's a lot of forms. I hear there's a lot of forms. What would be the one thing that you hope to see within your area of work, let's say in kind of justice, that you're going into, that will actually bring that level of support for people who identify as queer but may not have expressed that to a worker?
I mean, that's kind of difficult for me to answer just because I haven't started the post yet. I think, and maybe this isn't, universally applicable, but actually being a transgender social worker, I'm a bit of an anomaly. And so working with other queer people, that tends to actually work in my favor and their favor in terms of building our professional relationship. I used to work in asylum support services, and I worked with a couple of transgender service users who, since coming to Scotland, had not worked with another queer person and felt like they spent a really big portion of their very precious time with professionals, because we have limited time face to face with our clients, trying to explain what they needed them to do and what was happening for them. Whereas one of the reflections that they had when we worked together was we were able to actually focus on the work, as opposed to spending 3/4 of a half an hour session with them kind of painstakingly explaining the needs of trans people. So I think something that everybody can do, because obviously, look, we can't all be trans, as fabulous as it is educating yourself. We have, the internet is a huge resource that is available to us, especially those of us who work in social services. We have access to databases. We know where to go to look for things. And so taking a little bit of time, even if it's an hour a month that you have to sit down and be like, I don't know anything about this and I'm going to go and look for it. If training isn't, formalized training isn't available to you, that's something that you can do just to have yourself be slightly more prepared for coming into contact with people who maybe you don't know anything about their lived experience up until that point.
Great, thank you very much. And again, a lot of loves and claps because you are fabulous. Great. Is there any other questions that we've got from the floor? Not that many. Great. Okay. Well, you know what? I think I'm going to let everybody off since it's a lovely Thursday. Yes, we've got a kind of comment here. And it's true, I've been a practitioner of all sorts of different in different places and settings, and it is a big challenge to even keep up to date with the different terms and words that we use for different groups of people, different groups that are all rightfully shouting to be seen and to be visible and to be respected in the way that they should be. And it is quite a lot. But if we have come into an environment where we are there to support people, I think the idea of making the effort should be there. And whether or not we eventually get to it or be very supported is another issue that I think management needs to address. And I personally think that this should be something that can start from a more national level of support, just to, again, make it visible, that make it really obvious that all groups are being seen, all groups are being supported. How it trickles down and how it's operationalized obviously will depend on the services and how good the management there is in supporting such changes. But yeah, but I do think that a lot of the things should come nationally. So if there's ever any opportunities for people to feed into national campaigns, national kind of evaluation of what we should do as a nation, hint, hint, the kind of the SHBBV framework kind of for Scotland is really up for review really, really soon. So I think all the feedback going into that will be really, really helpful just to start fresh, to really put into context where we are at now in Scotland, 10, 11 years on from the previous framework. Let me just put another one up, another comment here.
Yeah, I think that's right. I think that's actually my partner who's sitting in the living room, who saying that it's not like taking away the parts of being LGBTQ and a substance user that are difficult means that the rest of it is all really easy. Like LGBTQ people using drugs are already starting from a disadvantaged place when compared to their like cis-het substance using peers, because they still have the same level of work to do and the added on extra bits. I also just wanted to say, I'm going to drop my email in the chat. If anybody would like the full copy of the dissertation paper, feel free to email me and I will send that to you.
Cool. I'm going to put one more comment up, which I think it's very, it's very important, and it is very tiring. I've been in sexual health world with youth work for the last 15 years, and certain things move and certain things just refuse to move on. So I think we all individually should take on some responsibility to try in our everyday ways to either role model or to actively, if you've got time, to find resources and make it so obvious that people cannot not do it almost. And if they don't do it, then it's very obvious that they are not doing it. So I find it quite a useful way to kind of really encourage people to really get on with the program. Cool. Thank you very much for that. Thank you, our speakers, and thank you for the engagement from the floor as well. So before we go, again, round of applause to everybody. And we're going to have the 3 polls that is going to come up for you to share with us what you think about the session. And if you've got any questions, again, you want to email the different speakers, the information should be in the chat. You can always pop me an email as well, or you can see me later on at Zumba. That's as much as I'll say. Thank you very much. I'm going to turn my camera off while the poll is running because it got a bit awkward, me just staring into the screen in the last few sessions. So thank you very much for attending this session. And there's going to be a half an hour break, I believe, before we start the next session. So see you later.
Thank you.